Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on simultaneous evaluation of multiple living kidney donor candidates is hosted by the AST Live Donor Community of Practice. Before we begin, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the MyAST website within 24 to 48 hours after the session. Please note that all of your lines have been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the journal club, we encourage you to participate by using the Questions tab in the GoToWebinar panel to submit your questions for consideration. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a short survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Krista Lentine from the St. Louis University Transplant Center in St. Louis, Missouri, to begin our presentation.
Thank you very much, Brian. Well, good afternoon, everyone. And on behalf of the AST Living Donor Community of Practice, we'd like to thank you all for taking the time to join us for today's Journal Club. Our topic today is the recent article, Evaluating Multiple Living Kidney Donor Candidates Simultaneously is More Cost-Effective Than Sequentially. And again, I'm Krista Lentine from St. Louis University, and I'm honored to co-moderate today's program along with Dr. Neekita Garg from the University of Wisconsin. We're delighted to be joined today by our speakers, Drs. Habbous and Drs. Amit from Western University in London, Ontario. And if folks could mute, that'd be great. Who will be presenting their work as lead authors of the study. By way of housekeeping, please note again that audience members can type their questions into the chat box at any time. And we plan to open the session to questions on the article about midway in the program. And then Amit will provide some commentary and description of the group's broader research agenda to wrap up the program. Next slide. So our disclosures include memberships on AST committees, service to the Scientific Registry of Transplant Recipients, and grant funding in living donation research, but we have no conflicts of interest related to this presentation. So we'd like to begin with brief framing on the larger context for this study, which is particularly timely policy initiatives. And the background is, as we all know, that kidney transplantation improves quality and quantity of life over dialysis. Recipients of living donor transplants clearly have better outcomes, including superior allograft and patient survival. But live donor transplant is the least common treatment option. Further, while there are nuances with regard to measurement, it's generally accepted that survival after transplant is worse with longer pre-transplant dialysis duration. So there are outcomes advantages to getting patients transplanted relatively quickly. Comorbidity can progress on dialysis, and there is also a risk of becoming too sick or even dying before an organ offer. In the United States, the federal government is deeply invested in the care of patients with kidney disease, and the establishment of disease-specific Medicare entitlement in 1972 expanded dialysis access across age and comorbidity profiles. But in concert, Medicare spending for kidney failure has grown exponentially. And total spending for the care of patients with kidney failure in the United States now totals $36 billion, most of that for in-center dialysis. So this combination of improved outcomes and lower costs makes a strong economic argument for transplant, especially living donor transplant. And compared with dialysis in the United States, living donor transplant has shown to be especially cost saving. Now, with regard to policy, recognizing that the predominant use of in-center hemodialysis, the highest cost and lowest benefit renal replacement treatment option, does not serve the best interest of patients and has challenging economic sustainability. In July 2019, the federal government launched a historic initiative to shift practice patterns. This was done through the Advancing American Kidney Health Executive Order, with a blueprint centered on three broad goals, including improving access to and quality of person-centered treatment options and increasing access to kidney transplants with a focus on living donor transplantation. To put the order into action, just last month in September 2020, the ESRD treatment choices model was announced, and this model adjusts Medicare fee-for-service payments to participating nephrologists and dialysis facilities based on home dialysis and transplant rates, where transplant rate is currently defined by a combination of waitlisting and living donor transplants. Within our professional community, there is a clear recognition that living donor kidney transplantation is the best treatment option for most patients with kidney failure from both a patient-focused and societal perspective. However, a 2015 AST consensus conference noted barriers to making live donor kidney transplant a reality for many patients, and in particular, evaluation efficiency was highlighted as a key challenge. In 2017, the KDIGO Living Donor Guideline recommended that transplant programs should conduct as efficient a donor evaluation as possible, meeting the needs of donor candidates, intended recipients, and transplant programs, but also noted the need for more work on defining and implementing efficiency. The living donor candidate evaluation is a complex multi-step process with uncertain outcomes that has been challenging to map, measure, and improve. Fortunately, Drs. Habbous and Garg have taken this topic on. And so now we'll turn to Steve to discuss the details of his recent study in Kidney International.
Wonderful. Thank you so much for that introduction, and thank you all for joining me today. I'm excited to talk to you about what we can do when we have multiple living donor candidates coming forward expressing interest to donate a kidney to the same person. So just a little bit of context. This is not an uncommon scenario. So we reviewed the medical charts of all persons who contacted the Living Donor Program in London, Ontario, Canada. And this is a medium-sized program. Between 2013 and 2016, a median 2 to 4 living donor candidates expressed interest to donate to the same recipient. So that's not a very small number. So one question we would have is, well, how does the living donor coordinator handle this? So typically they would prioritize the candidates. At the outset, they would collect some general health information such as age, medical history like smoking, BMI, hypertension. They would also consider ABO compatibility, as well as the preferences of both the intended recipient and the donor candidate. And this is all important. So the living donor coordinator will typically take all of this information and as well as the perceived motivation of the candidates and the relationship between the donor and the intended recipient, and will typically prioritize one candidate over another to proceed with the living donor evaluation process. So why do we do this? Why do we evaluate one at a time? Well, there are some good arguments, don't get me wrong. So namely, we want to avoid unnecessary testing, and doing so reduces the burden on healthcare providers and donor candidates. The evaluation process is quite onerous. It takes a long time, requires time from various healthcare providers that they wouldn't be able to spend with other people or other patients. And on donor candidates, they have to take time away from their work, from their other responsibilities to show up to do the testing, and it's quite onerous. It also reduces costs to the healthcare system and donor candidates. The cost to the healthcare system included cost for consults, visits, various testing, and for donors as well who have to take time away from, making money or paying for parking, paying for travel. And so this is why we try to avoid unnecessary testing. However, I'm going to flip this a little bit on its head and argue for the converse. So evaluating one at a time could actually increase costs to the healthcare system, and it could also result in worse patient outcomes. Now, here's the reason why I'm saying that. So first of all, not all candidates will ultimately donate. Second, the evaluation process is lengthy, and that length has consequences. And last, the cost of the evaluation is relatively small. So because these are fairly important components, I'm going to be talking about each of them in turn. Number one, not all candidates donate. A recent scoping review of the literature identified a handful of studies, so about 20 or so, that reported on the number of living donor candidates who came forward and the proportion of those of that pool who ultimately donated. So across all these studies and pooling them, we have about 36% of candidates who ultimately donate. And this does depend on what the denominator was, whether it's all people who came forward or those who passed some checkpoint. As you can see, the heterogeneity is quite broad here, but this is the best estimate that we have so far. And there are many reasons why a living donor candidate does not ultimately donate a kidney. And I group these here into three broad buckets. The first bucket is the non-modifiable factors. So one example would be the donor candidate has chosen not to pursue the donation, or the intended recipient declined the offer. Other reason would be the donor candidate was deemed medically unsuitable for donation. Now these are not modifiable because we don't necessarily want to change these things, nor would we be able to. The second group is the somewhat modifiable. By that, bear with me, you'll see why they are somewhat modifiable. So the first reason would be, for example, the intended recipient is no longer eligible for transplantation. And this could be because the health of the intended recipient has declined or has deteriorated over time, or they may have received an infection, or they could have even died. And those are important reasons why they would not receive a living donor transplant. The second reason would be the intended recipient received a deceased donor kidney transplant. And this is important as well because the intended recipient, even though they have a living donor who came forward, can stay on the deceased donor wait list. Now, these are somewhat modifiable because they are time-dependent events. The likelihood that these events will occur increases the longer you follow a recipient. And so we could conceivably modify these events from happening if we had, for example, a more efficient living donor evaluation process. So if we had a faster time to work up a donor, then we may avoid some of these outcomes. And that is why addressing inefficiencies in the evaluation process is listed under one of the most modifiable ones. Another modifiable reason for non-donation is preferring another donor candidate. And this is the crux of the matter. So if we have multiple candidates, choosing one over the other is one reason why not all candidates donate. Number two, the evaluation process is long. So a recent study and review of the literature showed that the median time from the start of the evaluation until donation can exceed 10 months. And that is a long time. Granted, there is obviously a lot of variability across transplant centers, but this is the median that we found. And this time period is rife with uncertainty. We don't know. So the donors don't know if they're going to be able to donate. The recipients, the intended recipients, don't know if they're going to be able to receive a kidney. And that uncertainty produces a lot of anxiety. And the multiple testing, multiple visits, and the time frame itself can lead to frustration for living donor candidates. And this length of this process has consequences. So it can result in a loss of donor candidates. They may abandon the process because they're frustrated. And we know this happens by speaking with living donor candidates and prior living donors as well as recipients. We know that this is happening. And there is some evidence in the literature to suggest this is happening as well. The second consequence is that this can result in a loss of recipients due to those competing events I mentioned earlier, such as death or illness resulting in transplant ineligibility, or receipt of a deceased donor kidney transplantation. And number three, the evaluation is not that costly. So first, I say the evaluation is costly. because it is costing about 3,600 Canadian dollars or 2,700 US dollars per evaluation. And we assume half that for the non-donors, so those who are ruled out. But if we take that into perspective and compare it with the cost of maintenance dialysis, which runs about, say, $80,000 per year, it's not that costly. Even if it is plus minus 40,000, the cost of the living donor evaluation is really a small proportion of what maintenance dialysis costs. So with that in mind, we created a simple decision tree to compare two strategies when two living donor candidates come forward to donate to the same person. Either one, we evaluate them one at a time, or we evaluate them both at the same time. And with these two strategies, we produce this model and look to see what are the costs. So health system costs, so these are the costs to evaluate, the out-of-pocket costs. So we took a societal perspective, as well as recipient outcomes and quality of life. And we'll go over these next. So the model is a simple one, meaning it was a simple decision tree. And we created three different scenarios. The first one is the simplified base case. So what this means is that we took away any possibility of anything other than donation or no donation. So we removed the possibility of competing events, which means the intended recipient was not allowed to die or lose transplant ineligibility. We also required that the intended recipient was on dialysis when the living donor evaluation started. In the second model, we allowed those competing events to occur, which means the model could end at donation, no donation, recipient ineligibility, or deceased donor transplantation. And in that model, all recipients were on dialysis at the outset. And lastly, in the final model, competing events were also present, but the intended recipient was not on dialysis at the outset, which means they could, in theory, receive a preemptive transplant. So now delving into the costs and evaluation times. So these are some of the parameters that we used to inform the model. So briefly, the evaluation costs, we have the health system costs for both the donor and the non-donor. So for the donor, it's about 3,600 Canadian or 2,700 US. And for the non-donor, we assumed it was about half that, and it was time dependent. And by time dependent, I mean if the patient or the donor candidate was ruled out, say after a month, it would probably cost less than a rule out after, say, 7 months. Likewise, for out-of-pocket costs for both the donor and non-donor. We also have a penalty for a delayed evaluation. Previous empirical work from population level demonstrated that longer evaluation times were actually more costly. And so we factored that in at about $47 per month. There was also another penalty. This is for the third model, where in the preemptive scenario, where if the intended recipient started dialysis midway through the donor's evaluation, the cost of the living donor's evaluation was greater, and it was greater by about $886. In terms of evaluation times, so the evaluation time from the start until donation, we said was 10.3 months, and we assumed it was half that for those who are non-donors. And there was also another penalty. Previous research showed that if the intended recipient started dialysis, the total time from when the donor's evaluation started until transplant was twice as long. So in that scenario, for example, the donor evaluation time wouldn't be 10.3 months, it would be 20.6 months. Okay, in terms of events, we have the probability that a candidate was donor eligible, which means they ultimately donated if given the chance. And that was the 36% that we showed earlier. There's also the probability of starting dialysis. This is for the potentially preemptive scenario, and that was about 35%. But keeping in mind that they don't start dialysis right away. So if they do start dialysis, they do so a median 9.7 months into the donor's evaluation. And we also modeled the risk of competing events, including the rate of death and the rate of deceased donor transplantation, and that varied depending on whether or not the intended recipient was on dialysis. Lastly, the quality of life. So we incorporated the quality of life for the health states. So you can see transplant versus dialysis. So there's a positive utility of 0.11, which means quality of life is higher for patients who received a transplant compared to those who were on dialysis. We also included a disutility, so it's like a one-time penalty for quality of life for starting dialysis. And the living donor evaluation is not, entirely fun. So there are complications, for example, an allergic reaction to the CT angiography dye or incidental findings as part of the evaluation. So we included these as well, and they had their own utility scores. Okay, so those are the parameters of the model. Now let's assume the candidates are evaluated one at a time. If we do that, there are three possible outcomes. The first outcome is probably the best. The first candidate you evaluated ended up being a donor, and that's great. You didn't conduct any unnecessary evaluations. So we didn't evaluate the second candidate, so we saved money from doing that. And we didn't subject that donor candidate to an unnecessary evaluation. So that took about 10 months and cost about 3,600 Canadian dollars. The other potential outcome is that, okay, the first candidate did not donate for whatever reason. Then we evaluate the second one. So the second possible outcome is that second candidate ended up being a donor. So that's fantastic. It took a little bit of extra time to get there because we evaluated the first candidate first, but we did get there. So it took about 15.5 months and cost 5,400 Canadian dollars. And the last possible outcome is neither candidate ultimately donated. And so it really made no difference whether you evaluated them one at a time or together. It took about 10 months and cost the same. So when we put all this together, we multiply all the probabilities by the times and the costs, we get an expected time of 11.5 months and an expected cost of about 4,000 Canadian dollars or 3,000 US dollars. Now let's assume the candidates are evaluated at the same time. In this case, there are four possible outcomes. The first outcome is both candidates are eligible. So that's awesome. What are the odds? But it was great. We did do an unnecessary evaluation because really only one donor can donate to that recipient. So we spent an additional $3,600 evaluating that second candidate. The second possible outcome is that only candidate A is eligible. In that case, we evaluated candidate B unnecessarily, so that adds to the costs. Conversely, only candidate B was eligible, so we evaluated candidate A unnecessarily. And lastly, none of the candidates were eligible. So both ended up not donating. Again, so it makes no difference if evaluated one by one or simultaneously. Cost the same outcomes, but at least you'd get the answers sooner. So when we tabulate all these findings, we get an expected time of 8.2 months and an expected cost of 4,900 Canadian or 3,600 US dollars. So now let's put this side by side. So in terms of health system costs and out-of-pocket costs, the simultaneous evaluations cost more, which isn't necessarily a surprise. And so the difference in the difference column is simultaneous minus sequential. So in this case, simultaneous is more costly than the sequential evaluations. However, this does not tell the whole story. When we factor in the evaluation time, the simultaneous evaluations saved 3.3 months overall, and 1.2 months of that time was on dialysis. And dialysis, as you know, is fairly costly. And so when we factor that in, we get a net savings of dialysis cost of about 8,800 Canadian dollars. And when we factor in the out-of-pocket costs and the health system costs to evaluate the donors and the candidates, we get a net cost savings of 7,700 Canadian dollars or 5,700 US dollars. In terms of quality of life, it is in the positive direction. So you can see the difference of plus 0.1312. So the magnitude is not important. What is important is that it's in the positive direction, meaning overall quality of life was improved. And QALM is quality adjusted life months. And the reason why we're not reporting qualities is because such a short time frame that qual M is more interpretable, I guess. And there are some other outcomes that we will be reporting on, such as the probability of donation. So in this case, it was the same because this is a simplified case. And so all evaluations ended up in either donation or no donation. And likewise, starting dialysis. Everyone here was already on dialysis. So in the next model, you'll see some of these are actually coming to term, the probability of donation. So this is the second model where everyone is receiving dialysis at the outset, but now we have those competing events. So let's focus on the total cost for now. This is from the societal perspective. Again, it is cost saving to evaluate the donor candidates simultaneously, saving about 5,600 Canadian, 4,200 US dollars. Quality of life is also improved, and the probability of donation is increased. And that increase of 1.07% is due to a reduction in the risk of deceased donation and a reduction in the likelihood of transplant ineligibility. And the driver behind that is the shorter time until donation, which in this case was by 0.9 months. Okay, and in the last model, this is in the potentially preemptive scenario. Again, total cost is negative, so it is cost saving, less so than the other models, but it is still in the favorable direction. Positive quality of life, probability of donation is higher, again, due to a reduction in the likelihood of deceased donation or transplant ineligibility. And simultaneous evaluations also reduced the likelihood of starting dialysis by 2.2%. So next, we look to see what is the reason behind these observations. What parameter or parameters are really influencing these results? And so we did a one-way sensitivity analysis. And by doing so, what we do is we take every parameter one at a time and change the value from what we would expect to, say, the lowest conceivable value that we think is plausible. And then we would change it to the highest value we think is plausible. And then we would see how does the outcome change. In this case, the outcome is the total cost from the societal perspective. And this funnel plot is for patients who were on dialysis at the outset. This green vertical line is the point of $0. So once we go into the positive domain, that means simultaneous evaluations is no longer cost saving. This red line is the expected value that we currently have. So if you recall, for this model, it was negative $5,600. Okay, so by changing this parameter, the results are simultaneous evaluations are more cost saving if the second candidate is donor eligible. So what that means is that because the second candidate is going to be the donor or has a higher chance of being a donor, that candidate is evaluated at the outset, which makes simultaneous evaluations more cost saving. Conversely, it is simultaneous evaluations more cost saving if the first candidate is donor ineligible. Again, because you want to evaluate the other candidate first. Simultaneous evaluations is more cost saving if it takes longer to rule out the first candidate, which makes sense because you want to be able to get to the next candidate sooner. So the longer it takes to do so, the more cost effective it is to evaluate the second candidate at the same time. And this one is a little bit important. It's a bit different. So this one is a sensitivity analysis. The results state that simultaneous evaluations is less costly if evaluating candidates at the same time slows down the evaluation for everyone else. So this is an indicator of resource constraints. So to put it in different terms, if a program started evaluating everyone at the same time rather than one at a time, then it slowed down the process for everyone. So instead of the average time being 10.3 months, it would be maybe 15 months, 16 months, etc. So this was a proportion. It was a percent increase in the total time to evaluate a candidate. And lastly, it was simultaneous evaluations were more cost saving if dialysis was more costly. And that one's pretty intuitive. You get bigger bang for your buck if dialysis is more costly. Okay, So in the next slide, we'll look at the third model. So in the potentially preemptive scenario, everything here is going to be the same, but I want to focus on two key differences. One is this first variable. So this input was the effect of dialysis start on the donor evaluation time. So if you recall, starting dialysis prolonged the time until donation. So for example, if the recipient starts dialysis, can they receive a transplant the next day? Do they have to wait until their health stabilizes for a month, 2 months, 3 months, etc.? And so if there was no impact of starting dialysis on the evaluation time, then it would be less cost effective to evaluate candidates simultaneously. And lastly, it is less cost saving if starting dialysis is less likely, which makes sense. So if we said the patient is never going to start dialysis, so the probability is 0, then you can take your time. There's no reason to evaluate them at the same time. So in conclusion, simultaneous evaluations is cost saving and more effective, making it the dominant strategy when compared with sequential evaluations. And this is driven by the shorter time until donation. We expect more living donor transplants because of fewer competing events, such as death or transplant ineligibility. We expect better patient satisfaction because of a shorter time until donation or even until rule out. And with a savings of 5,600 Canadian dollars or 4,300 US dollars per pair evaluated, adding additional resources to enable those evaluations may be justified. Lastly, the impact on a transplant program really depends on how many pairs of candidates it receives. Okay, thank you.
Thank you, Stephen, for the excellent presentation. We'll now begin with the discussion, and I just want to remind the attendees that they can type their questions into the chat section. The first question that's coming through is with regard to the process of evaluation. Your study shows that evaluating candidates simultaneously is cost effective from a societal perspective. However, as you acknowledge, conducting more evaluations can be viewed as burdensome for the transplant centers who may not have the wherewithal to perform multiple simultaneous evaluations in all cases. So the first question that's coming through is that if a center determines that they have the ability to do some simultaneous evals, but not in all cases, can you make recommendations on what groups they should focus on? In other words, are there certain subsets where doing simultaneous evals is higher yield than others?
Thank you. That's an excellent question. I guess a rather fun one is where to start. So I suppose the highest yield would be found with respect, well, at least with respect to cost savings, would be to prioritize the simultaneous evaluations for patients who are receiving high cost dialysis. So for example, in-center hemo. Another high yield group would be patients nearing dialysis, where the probability of starting dialysis while the living donor is being evaluated is higher than the average.
Thank you. Another question that's coming through is what do you recommend in terms of handling multiple donors? What if a potential candidate has up to 20 donors coming through a social media post? How many donors do you recommend looking at until, how many is the maximum you can look at until you still have the cost benefit to be seen?
Yeah, that's an excellent point. And we've seen that when we compare the median versus the mean from that chart review, the mean was about 7 by 2016. And we've encountered cases where 20 plus candidates do come forward at the same time. In the current work, we only modeled up to 4 candidates, and it was still cost saving up until then. So we can't really answer anything above that. And there is probably going to be an upper limit. And I think a living donor program will have to prioritize what they can do.
Okay. So yeah, to summarize, so in your paper, you saw benefit with up to 4 donors at the same time.
Correct.
Another
the practical issue there, can I go ahead?
Yep.
Another question that's coming through. Sorry, go ahead, Amit.
Yeah, sorry. The practical issue often is that you only have a given number of living donor nurse coordinators in HR. So when we get like these social media posts and we get like 30 plus candidates contact our program, what do we do? And it depends really also how much of your evaluation is automated versus requires coordinator time. And also there is an equity issue because you want to make sure there's enough people to like to have everyone at least have one person under evaluation. And so if you overrun your program resources with several candidates and that disadvantages other candidates, that's a consideration.
Yeah, that's an excellent point. Thanks, Amit. The next question that's coming through is, what impact do you think simultaneous evals can have on non-directed donation rates? Can you comment on that, please?
Yep. So we've come across a few instances where a living donor came forward, completed most of their evaluation, and unfortunately were no longer able to donate to the person that they intended to donate to, either because maybe they died, they received a deceased donor transplant, or they received another living donor transplant. And in a handful of cases, those candidates who did not get to donate often do pursue non-directed donation. I think the proportion is fairly low, maybe 1 to 2%, but it also depends on how transplant programs solicit or advertise the possibility of even donating anonymously.
Okay, thank you. Krista, I think you had the next question.
Yeah, thanks a lot. So, Amit, you alluded to resource constraints, and I think an important observation in your in your paper is that the benefits are from the societal perspective. So the payments that are made to dialysis centers and to transplant centers are effectively separated. In the U.S., donor evaluation costs can, at least for Medicare insured recipients, can be billed to the cost report. So centers can take into account the coordinator time that's spent and potentially justify adding an FTE, but still that can be challenging. So do you have any comments in terms of how centers should be using this to kind of adjust the funding of their staff for this? And then there was a question that came in related to that about how type of insurance factors in.
Right, thank you, Krista. In truth, even in my own jurisdiction, the evaluation of living donors is a lost leader in terms of payments by the provincial government to the transplant center. So there's a fixed amount for the actual transplant incurred, and that includes the evaluation. So a center often is using its surgical budget to offset, or other parts of the budget to offset the cost evaluation. And it is, just like you're describing in the US, a funny system in the sense that you don't look at the overall health system benefit. You have a siloed transplant center with its source of funding, and you have a siloed, we call them in our jurisdiction, regional renal program that cares for advanced CKD patients and dialysis patients. It has its own funding. And often the way that payments are made don't look at the overall system. So there's no answer to your question. It just raises the challenges in addressing this. And finally, you might have a fixed cost per evaluation, but at the end of the day, you have to manage this from an HR perspective. And if you hire an additional 1.0 nurse coordinator for your program, that's a fixed cost, and then you want to ensure the amount of activity supports that cost. So you have to actually look at that carefully.
Okay. Thank you, Amit. The next question that's coming through is the benefits of doing simultaneous evals, doing multiple evals at the same time really depends on efficient donor eval process. If more donors are being evaluated at the same time, we would want to make sure that that's not happening at the expense of efficiency, that we're not sacrificing efficiency to do more evals. Other than monitoring the average time from evaluation initiation to donor approval or making a decision on the donor process, what other measures do you think we should monitor? What other things are things we need to keep an eye on if programs are starting to do simultaneous evals more often?
I think that's an excellent point. So if If resource constraints due to simultaneous evaluations prolong the evaluation, then indeed it would no longer be cost saving. And I think we showed about 15% increase in time would be that neutral point. To ensure this isn't happening, wait times earlier in the process, I think, should be measured before and during implementation of the simultaneous strategies. So this would include things like time from when the evaluation started until various milestones along the process, such as time until CT angio, various consults, or other lab tests. Because the problem is, if we rely solely on the time from evaluation until approval, it may be too late, and the reasons for the delay would be masked. Qualitative data are also important to understand whether additional human resources are needed. So to Amit's point, the human resources to actually evaluate the candidates, that's something that we may not be able to capture quantitatively until it's too late.
Okay, thank you.
And maybe to add to this, in the next part of this presentation, I provide some thoughts on some additional measures that could be considered.
Thank you so much, folks. So efficiency and costs are really an important consideration. There can be others as programs are sequencing their evaluation, the clinical concerns, and even the preferences of both recipients and donor candidates. So if this type of evaluation moves forward, how do you recommend that centers who want to embark on this modify their education both to recipient candidates and to donors? In other words, what should we be telling our patients?
So that's a good question. Amit, did you want to fill that one?
Sure. So I think, as you say, Krista, it does depend on what the capacity is for the transplant center you refer to accommodate multiple candidates coming forward. As a broad comment, I think we want to support patients to find living donors and have those living donors come forward to the transplant center. And we want a message that you want to bring as many candidates forward because one, several candidates will be ineligible. And now this is the dimension that if the program is evaluating simultaneously donor candidates, that could also have a benefit. One of the considerations around this, as we all know, many of us who care for patients on dialysis and CKD, it's actually quite hard for people to bring forward donors. And so we just have to be mindful they're not putting too much pressure on them. First, bring forward one candidate and bring forward several candidates. So it has to be done thoughtfully without making the person feel like they're, if you lack of a better term, failing if candidates don't come forward. But I agree with you, Krista, that the messaging should be to identify candidates and bring as many forward as possible if that works well from a resource perspective for the transplant center.
Have you had any concern in practice about concern from donor candidates being worried that another donor candidate might, in some sense, the model projects it as a bit of a race, that the other donor might beat them, so to speak, in completing?
Yeah, that's true, and it is a good point. Sorry, go ahead.
That's fine.
I'm just thinking a little bit about our education to donors as well, if they're entering into this process and knowing that, that other donors are being evaluated and uncertainty in the outcome.
Yeah, and along the same lines, one related would be that if you have multiple, if you have two donors and both are approved through the donation, through the approval process, do you decide up front who's going to donate, or is it decided, after the fact?
Yeah, so this is a good question. Like one is, in my experience, having doing this for almost 2 decades, in truth, most cases, the donor candidates know each other. They're coming forward. They know that there are multiple candidates coming forward, and they're talking to each other outside of the transplant center. But there are some cases where that doesn't occur, and to acknowledge that. And if we have eligible candidates, then we kind of look at, sometimes they'll ask us, who do you think is best? And we might look at the cross match, and if there's a zero mismatch, we might say, okay, there's a graft survival with this certain donor. But most times we don't get that situation where donor candidates are equally viable. In that case, then we often have a conversation, like we say that sometimes there's an older donor candidate, and particularly if a young recipient, we might say there might be advantage of doing the older candidate now because given that the kidney might last a median of 15 to 18 years, the younger candidate would still be available. But I think, we also have to be honest, when there's no that a graft survival and donor risk is comparable, we have to open that up with permission of everyone to talk about it, and we let families decide in some part. But sometimes, in my own experience, families say, "Well, you tell us." In which case, we try to do our best.
Yeah. Sounds like an important patient engagement topic as well.
Thanks,
So,
Amit.
yeah, Neekita, go ahead with that.
What practical advice do you have based on, with your experience of doing simultaneous donor evals at your institution for other programs across the U.S. trying to do the same thing? What practical pearls of wisdom would you convey?
Some practical advice I would say is to revise your living donor evaluation journey to try to make it as less burdensome as possible on the living donor candidates, because if a center was to transition from a one at a time to a many at a time, they have to be able to accommodate that influx of evaluations without leading to burnout or even patient attrition, just because the evaluation process becomes inefficient as a result.
Yeah, that's really important. Thank you. Okay. I think we are ready to move on to Amit's piece of the presentation.
Yeah, thank you. So this picture just shows how we're moving candidates through all the hoops to ultimately become a living kidney donor. And you saw this consideration or how we evaluate kidney donors in a previous slide. This is another visual presentation of that. And this is now a few years old. It's even become more complex. But when we were creating our standard operating procedure for my own program, when we created our process map, it starts with the candidate contacting our program. But then it quickly balloons out when you see all the activities that occur in terms of trying to take someone from beginning to end. And ultimately, we result in providing a decision and enabling a living kidney donor transplant. But this topic overall about a kidney donor evaluation is causing us to consider our own experience as health professionals in this space. Like, think about how often you've been in a situation where a donor candidate stopped their evaluation and you couldn't contact them, so they didn't tell you they were stopping, you just couldn't contact them, and you perceived that they were quite frustrated with the process they were undergoing. Or their intended recipient died, or the intended recipient received a deceased donor kidney. Not all our donor candidates are planning to donate to someone who's active on the deceased donor list, but some of them certainly are, and some of them do get a deceased donor kidney while the evaluation is going on. Or how many times we've had a recipient develop a new medical event that precludes them either temporarily or permanently from receiving a transplant. Or how often we've been in a situation where a recipient was not receiving dialysis, and we have a donor candidate being evaluated. Sometimes that goes on for a prolonged period of time, and the intended recipient starts dialysis before ultimately getting their living kidney donor transplant. And just from a more human perspective, imagine if your partner was on dialysis and was eligible to receive a kidney transplant. Would you want them really to spend a day longer on dialysis than they needed to, or would you want them to start dialysis when they didn't have to? And this is really the crux of the issue. So I would say that this area has been an active area of research and investigation for the community. We personally have contributed 8 publications in this space over the last 3 years to help better understand how long the living kidney donor evaluation takes, how much it costs, how patient health care outcomes are impacted by a faster evaluation, and how best to measure the steps in the evaluation. This was led by Dr. Habbous, who you heard from earlier, who did many of these projects with the rigor of a PhD thesis. But many of us are also doing research with patients as full research partners, and I want to acknowledge that that occurred in this case for many of these projects. including previous recipients and donors. And there are multiple other colleagues who helped us with this work, including actually a professor from the business school who has expertise in operations research. And this is mainly for the archive. It just shows here the publications that are now available in this space that we've been involved with. And so just going through some of the data, how long does the evaluation take? You already heard this in some of the modeling, but at least according to this study, the total evaluation from start to donation was about 10 months. The time to approval, from start to approval, was about 8 months, and from approval to donation was a little over a month. If someone entered kidney pair donation, that increased the time, if they did get matched in the cycle, to about 7 additional months. And as described earlier in this seminar, sometimes this wait is totally appropriate and necessary. The recipient's not ready, the donor candidate needs time to think about things. But in my heart of hearts, as a director of a living kidney donor program who owns this issue, as many of you do, I sometimes feel the wait could be avoided. And what are our standards, national standards, when a well-motivated, uncomplicated donor with a ready recipient should receive an answer? There was some work done on this topic in that 2015 U.S. Consensus Conference that Krista described earlier in this presentation. And some of the consensus there was for a well-motivated donor, an uncomplicated donor with a ready recipient, it should take less than 3 months to give them an answer. But we really haven't fully fleshed that out yet, and I think that deserves some attention. Here's another study where there were 470 donors in 5 transplant centers in Ontario, where all donors did ultimately donate to their intended recipients. So these were all living kidney donor transplants ultimately, and the recipients were not receiving dialysis when the donor evaluation was well underway. And so what we found was that 1/3 of the recipients initiated dialysis before transplant. And this was a median of almost 10 months after the donor had started their evaluation. And once you restart dialysis, as alluded to earlier in the seminar, that's a period of high activity, also emotionally, physically, for patients and their families. And you really have to wait for some time for the dust settle before they ultimately have their transplant. So there typically was 8 months after they started dialysis before the kidney transplant. That dialysis cost was 8.1 million Canadian dollars to the provincial government. And a quarter of recipients initiated their dialysis urgently in hospital. While again, some of this would be unavoidable and not modifiable, some of this definitely could have been prevented with a better. Here's another study where we considered 900 donors from 5 Ontario transplant centers. And again, all donors did donate to the recipient. And here we took a base case where the evaluation time was approximately 11 months. And what would happen if we now ratcheted down that evaluation time so it went 3 months earlier? Well, it turns out if you're able to achieve that on average for your program, you can save about $12,000 per recipient. And when we were doing 220 living donor transplants in our province, that would save $2.7 million for the provincial government. 21 recipients would have avoided dialysis altogether. And because, again, some donors are active on the deceased donor, some recipients are active on the deceased donor waiting list, when they don't get their living donor transplant in a timely way, you lose living donor transplants. So this results in 57 additional living donor transplants per year. Stephen described a scoping review. There are about 275 articles now published that address this theme. Many of the studies describe the between center variability in the evaluation process. Are there any testing that we do that could be optimized to improve efficiency? For example, there's several studies looking at if you do need to look at split function because of, let's say, an asymmetric kidney size or something, can you take the volumes on the CT scan to replace the nuclear test of split function? There's some studies about the living donor evaluation experience with the evaluation process. And many donors are quite unhappy about the evaluation time. Again, it comes back to them seeing their loved ones on dialysis or approaching dialysis, and they want to avoid that or minimize that time as much as possible, and they want improvement. So in the questions that came up today is that how do you measure a quality living kidney donor candidate evaluation? And so this is also some work that Stephen led. This was a consensus building Delphi study where tried to understand how you could measure and develop process and outcome indicators for an efficient living kidney donor evaluation process. So the individuals who were polled on these measures included past donors and recipients, healthcare providers, healthcare administrators. They completed a survey, and then there was ultimately an in-person stakeholder meeting to finalize this. And this resulted in approximately 16 measures, process measures, 8 outcome indicators, and define the elements that you need to measure the process. Let me go through that a bit. Next slide, please. So first you have to define the key terms in this process, and there are some nuances here. So what if someone contacted program but is not really interested in donating right away, they want information? Do you make that the time zero, or do you make the time zero when they actually say, okay, now I'm ready to do my testing, and they have the first testing done, some blood work, etc. Also, some donors don't tell you they're withdrawing. They just no longer contact the program in between, like during their evaluation process, and they're voting with their feet in terms of they don't want to do this anymore. So you have to assign a time when they're ultimately no longer being evaluated, but how do you do that exactly? So these are some of the nuances when you're defining key terms in the evaluation process. Next slide, please. And then you have to just define your process indicators, like do you go from the time from decision to start testing till donation, or first contact till testing, or first contact to recipient referral. And so here are some measures for that. Next slide, please. And to give you more of a flavor, then you can have also outcome indicators like the total healthcare costs, the number of visits, number of transplants, etc. Next slide, please. I would be the first to admit, though, this is a good step forward, but there's still plenty of opportunity to improve how we measure a quality evaluation. For example, when you look at the 6 dimensions of quality care by the World Health Organization, a lot of the focus today has been on efficiency. But how patient-centered really are our processes, and should we be having more patient-reported outcomes or patient experience measures to see how we're doing? That becomes burdensome for data collection, but it raises some questions. And in today's society, it's all about equity too. Are there certain groups that are being disadvantaged by our processes, either whether that's by geography or income or race or gender or whatever lens you want to put on it? And do we want to make sure that our evaluation process is addressing everything correctly, and we put in strategies in place to address things like, for example, low health literacy, etc. So having it equitable is quite important. And finally, I think we all want to innovate in this space. Next slide, please. And so briefly, in terms of innovation, just to give you a flavor of what's happening. Next slide, please. This is a nice paper that caught many of our attention. This was a study from Northern Ireland where they were kind of doing what I call like a marathon day. They had a one-day donor assessment. So they come in 8 in the morning and you see get all these tests done, including their GFR, medical assessment, CT scan, and they finish by 4 p.m. that day. And ultimately, results are reviewed in 2 to 4 weeks by a multidisciplinary team, followed by the surgeon. And they were aiming to have the complete evaluation done in 2 to 3 months. And at least in this jurisdiction, there was some suggestion that this marathon day, one-day assessment type approach was associated with an increased number of living kidney donor transplants. So that's provocative. Next slide, please. Also, I think there's certainly a lot of lessons from the insurance industry, aren't there? Where for the customer experience, they have someone come to your home and they do everything pretty efficiently. They take your EKG through the phone. They're doing your surveys, they're drawing your bloods right there. And is there any lessons there that we can learn to make this process much more patient-centric and much more efficient, even from the center's perspective? Because if we can automate much of this with good donor candidate satisfaction, that could potentially allow us to be more efficient in dedicating our human resource time to where it's needed most. And then finally, many of us are getting experience with telemedicine. In my own region, I've now been doing telemedicine donor evaluations for now the better part of 6 months. they've been going well. I find when I see the donor candidate, it does still very much mimic if I saw them in person. This is particularly helpful for people who live a large distance away from the transplant center. And in our own program, I felt comfortable, as a nephrologist, generally felt comfortable. The social workers said for most candidates this works well. Our surgeons still want to see the candidates, so they haven't quite adopted this model yet. But I think there's real opportunity here to use telemedicine more efficiently to improve the experience and the efficiency of the donor candidate evaluation. And on that note, I'll end. I just want to thank the organizers for the opportunity to discuss this topic today, and together we can continue improving the experience of candidates who come forward to donate to their loved ones.
That is wonderful, Amit. And your last point just raised something that Neekita and I were chatting about as you spoke with regard to telehealth. One thing we wanted to ask you is if you and Steve had comments on how that may impact your estimates within your models. But then the other extension of that is, have you looked into other aspects of remote evaluation? So not just the interview and examination, if you will, but potentially remote lab testing and other kinds of remote evaluation services.
So when the modeling was done, it didn't account for this in any significant way. But if this results in improved efficiency, I guess this was accounted for in some of the data I showed. One of the questions I see in the webinar, would you feel comfortable approving a donor without seeing them? I don't think we would ever ultimately proceed with the transplant surgery with never seeing them, but we all, at least in my own program, we have a 2-week visit before, and we're rarely surprised when, at least this is my experience so far, when I've done the evaluation through telemedicine and they come 2 weeks before, that they didn't come as advertised and there was something quite different. I haven't had that experience so far, so it's been going quite smoothly.
Well, wonderful. So again, to respect everyone's time, we've reached the end of our program, and we want to thank our wonderful speakers, Neekita for the excellent moderating, and thanking everyone for joining us today in this robust participation. Any questions that not addressed will be answered by email this week, although we tried to cover everything, and you will also have access to the recorded programs and the materials for reference. Again, please complete the evaluation so we can continue to improve these programs. We wish you all a great evening, and Brian is going to give a final concluding remark.
Thank you very much, Dr. Lentine. AST would like to thank our panel and all of our attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about the AST Live Donor Community of Practice, please visit myast.org/COPS or connect directly to the LDCOP hub. Thank you all for today's session.